Welcome, everybody, to today's session. My name is Don Boudreau. I'd like to thank everybody for taking the time to attend today's session, the pharmacist's role in managing seborrheic dermatitis. I'd also like to thank L'Oreal Dermatological Beauty for their support of this webinar through an educational grant.
Thanks so much, Dom. Yeah, thanks for everyone joining. So today we're going to be kind of exploring the pharmacist's role in managing seborrheic dermatitis. We've got a lot to cover, so we're going to try to kind of keep on track within this 30 minutes. But if there's any questions, shoot them in the Q&A. So yeah, little disclaimer. So this information is presented by myself. And just to kind of put it out there, I understand the scope of practice is different in Alberta than it is in Ontario. And I know you guys are making great strides towards kind of more prescribing. So that's awesome to hear. I think Canada across the board is seeing the value of pharmacists in primary care. So if there's any questions, particularly around like scope, how would you approach it in our position, just throw it in the Q&A. Just some disclosures with respect to kind of some of the work I've done, some of the other companies. So learning objectives of the presentation we're doing today. So understanding kind of high-level pathogenesis of sebderm, including some contributing factors, common symptoms, locations of sebderm, to aid in proper identification and management, and then reviewing some prescription and non-prescription treatment options and how to effectively counsel patients. So dandruff is kind of like, so pityriasis is calpiti or dandruff, also kind of synonymous with sebderm is sebderm of the scalp. It's just a less, in most cases, severe form of it. So seborrheic dermatitis of the scalp can present kind of with those greasy flakes that kind of accumulate on dark clothing in some individuals. And it can vary based on the disease continuum from kind of light just like mildly noticeable flakes to more severe erythematic, dark, like thickened, plaque and greasy scales. The one thing to note is most of the time in dandruff, it's not as inflammatory as sebderm on like the face or possibly like pre-sternal areas, but it can be severe in some individuals. So there is that disease continuum. So what is the epidemiology of seborrheic dermatitis? So it affects approximately 5% of the world's population, but this is thought to be pretty well underreported just because it varies in severity. Some people experience it very mild, like very mild sebderm of the scalp, and they have it under control with your Head and Shoulders shampoo, or it's more severe in some individuals. So just the reporting really varies. Dandruff impacts about 50% of adults. So it doesn't really discriminate against ages. So infants, adolescents, young adults, older individuals about 50 years of age are all impacted by seborrheic dermatitis. Sometimes it presents differently in different individuals. So with children, you'll see like cradle cap, typically. It's approached a little differently than it is with adults. So it's something to note. You'll see this across all ages. And risk factors can vary from environmental factors, neurological conditions, and even like immunodeficiency. And I always say, like, with respect to immunodeficiencies, like if you have a cutaneous condition that isn't responding to conventional treatment, it is a bit of a red flag sometimes, right? Like, why isn't this, is there a resistance to the antibiotic we're using sometimes, or is there something else that's happening? So kind of be on the lookout for that. So the impact of sebderm on quality of life. So obviously, it can affect our self-esteem, can cause anxiety, depression in some individuals, and this has been studied. And with respect to how it physically impacts some individual, itch is a major complaint and can be debilitating seborrheic dermatitis. I will make one caveat though. Typically in the young infants, when you see cradle cap or presentations of seborrheic dermatitis, it's not as like obviously they can't communicate to us, but it's thought not to be as itchy. So there's that one reassurance there. But yes, in adults and adolescents, seborrheic dermatitis can be very itchy. So that's part of the treatment approach, right? It's we want to try to get things under control so patients are comfortable and they're confident in their treatment regimen. So what causes sebderm? So really it's a multifactorial pathogenesis to some extent, right? So the culprit is like sebum, like the seborrhea component. So you have a lot of sebum production. You have Malassezia yeast, which live on our skin, but there's a yeast overgrowth because they're feeding on that sebum. They're lipophilic yeast species, so they love that sebum. So they end up, when they feed on sebum, they end up kind of excreting and like byproduct, which can cause inflammation on the skin, which compromises the skin barrier, which kind of creates that cycle of inflammation, right? So when we treat seborrheic dermatitis, we're really trying to treat like that multifactorial component, the inflammation, the yeast overgrowth, the sebum in some extent, and then trying to also normalize that skin barrier again, right? And the hydration, moisturization is a component of it. So when we look at the scalp, for example, so the scalp microbiome is different than the forearm, the cheek, the forehead. So kind of if you're familiar with acne pathogenesis, that C. acne, that Cutibacterium acnes, that is a major component of the scalp microbiome. But it works in a positive light on the scalp just because with more sebum in the scalp, being a highly sebaceous area, those C. acnes feed on the sebum and they actually exert byproduct that helps kind of balance the scalp microbiome. But when you have a Malassezia kind of overgrowth in the scalp, you'll get that dandruff, that seborrheic dermatitis. So that imbalance can really contribute to seborrheic dermatitis. And you'll see there's Staph aureus living on the scalp, staph species. And we know when there's a staph overgrowth, sometimes it can result in a staph infection of the scalp. So just depending on the bacterial kind of microbiome ratio is really going to impact what happens there. So just a little bit of visuals for you. So kind of sebderm in a nutshell. So it's a chronic relapsing condition. Unfortunately, this is something people will have to treat if they experience it as an adult or adolescent on a pretty regular basis, like depending whether it's the dry weather or it's cold or if there's environmental factors that are contributing. Some people have it under control well, certain times it'll flare. So that's kind of where the maintenance and the active treatment will come with the therapeutics. Severity will vary for a lot of different individuals, and that's going to impact how well it's reported. We see across clinical components. Healthy individuals are affected. It's associated with immunocompromised patients. So keep an lookout, not maybe just in sebderm, but really in any cutaneous condition when you start seeing unconventional or conventional treatment not being responded to. And it doesn't discriminate against ages. So how does seborrheic dermatitis clinically present? So, well, you'll see on the scalp, the face, those hair-bearing areas, that sebderm, it will present in those areas where so I guess you have a high amount of sebaceous glands, right? Pre-sternal areas, intragenous areas. And this on the face, you'll see typically it'll be symmetrical. So you'll see like both eyebrows being affected. You'll see kind of the beard symmetrically being affected in individuals with facial hair, both ears being affected. It's not just going to be unilateral in presentation. So that's kind of one thing. It's usually arithmetic, like greasy scales, right? You don't see plaquing, and that's different than psoriasis. You'll see kind of like loose, greasy scales. Sometimes in the scalp, you'll see thicker, but they'll still be kind of greasy scales. So that's one piece to kind of be aware of. In the scalp, it'll range again that disease continuum from mild, moderate, severe. So you'll see in mild individuals with dandruff per se, you'll see more so just that flaking. It's slightly noticeable, moderate, a little bit of erythema, redness happening, and in severe, that notable thick scaling. And they'll typically complain of itching, and itching is going to be a common symptom you'll see with people who have sebderm. Yeah, so we'll kind of move on here. So the biggest thing is, and I always talk about this, is like don't get into the little hole of like diagnostic bias, right? Dermatology is a very visual field of medicine, and even with like dermatologist expertise, they will sometimes biopsy pretty regularly just to be on the confirmation side once they get down their differentials. So it's good for us kind of in the primary care role to be aware of that, right? Because psoriasis, although it'll have that scaling, that erythema, the scaling will present more silver. And with psoriasis and atopic derm, you'll get it more on flexural areas before you get it on the more conventional sebderm areas. But psoriasis will also present in a lot of different forms. Atopic derm is associated with a lot of itching, but again, in those flexural areas, those elbows, those knees. Tinea corporis, you'll see tinea typically with erythema. If it's presenting in the scalp, sometimes it can cause hair loss, but it won't present. But with sebderm, you won't get that hair loss. Rosacea, you'll get erythema with telangiectasias right on the face, whereas with sebderm, you're not getting that that like notable just erythema. You're getting that scaling with it. Perioral derm, you'll get papules, and it's pretty localized to that perioral region. Whereas with sebderm, you're going to get the scaling, the erythema, but it'll kind of extend right to like the hair-bearing areas, the ears, so on and so forth. And also, like part of your assessment, your differential, it's going to be important to note that like getting that beginning, middle, end to a story is going to add to your comfort in assessing, your comfort in recommending. Because with contact derm, for example, it's typically there's a culprit, right? So if a patient says everything has been great, I started this new foundation or I started this new shampoo and things just got really itchy and red, typically we're going to lean towards more of an irritant or contact dermatitis. So it's good to just kind of keep some things on your differential or on kind of the other options that might be there. So I kind of just presented some slides just to kind of say, okay, what could this be? Why? Like it could present like sebderm, it might not present like sebderm. So you'll see kind of on your left, like you get some scaling there, some yellow, a little bit of erythema there behind the ear, but you'll get some erythema, a little bit of scaling. But the difference in the scaling between the left and the right is more silver, the left is more that yellow tint color. So when you move on, you'll see that psoriasis has more of a silver scaling and seborrheic dermatitis is more of a greasy yellow scaling. So very similar, but different in essence. Moving on to something affecting the scalp, right? So you'll see on the left, you'll get erythema. It looks like there's some alopecia happening or some hair loss in general. And then on the right, you'll get more of that thick, notable greasy scaling happening. And when we move on, you'll see on the left, you have tinea capitis. On the right, you have seborrheic dermatitis. And that's because typically sebderm doesn't usually associate with any hair loss. So what are the goals of treatment for seborrheic dermatitis? Well, to control signs and symptoms and improve quality of life, right? If we can get itching under control, if we can get that self-esteem for those patients who are severely impacted by it, they're going to be much more comfortable with continuing maintenance treatment as well. So how's that done? So again, multifactorial, reducing that Melissia skin colonization, modulating sebum production, controlling inflammation, and addressing skin barrier dysfunction. And sometimes you can do that with one product. Sometimes it might take a couple different products. So that's just good to be aware of. So what is our treatment toolkit? So obviously we have shampoos, which we typically use in dandruff or sebderm of the scalp. And then we have a lot of different topicals, right? And just full disclosure, like a lot of topical treatments are sometimes considered off-label. Like you'll see topical calcineurin inhibitors are typically indicated for atopic derm, but we use them very commonly in sebderm. And I think just of recently, there's only really one Health Canada indicated product, and that's roflumilast or Zorifoam for seborrheic dermatitis right now. So you'll see a lot of different options on the topical side. And I know steroids sometimes have a bad rap, but they do have a place, especially when we want to try to get things under control for patients, because patients' priorities is usually to get things under control. So available treatments for sebderm of the scalp or dandruff. So you have a few different options. You'll notice something pretty common across all these, and you'll see like selenium sulfide and Durcos, selenium sulfide inside of the Selsun Blue, the keto, and the Nizoral, the zinc in the Head and Shoulders. And it's module at that antifungal, antibacterial component. So that's kind of where being familiar with those active ingredients can help understand what they're doing. I do really like the Durcos just because it's got that antifungal, antibacterial component with the selenium sulfide, but the salicylic acid is a keratolytic, right? So when you have that scaling happening, you want to try to push that off. Caveat, not in children. Children when they have cradle cap, you don't want to use keratolytics. That's why it's recommended that they work with their family physician or their pediatrician if that's presenting, because they'll typically have a referral to a derm at that point. But yeah, vitamin E, ceramides, you'll see like the Durcos product is helping with the antifungal or the yeast component. The salicylic acid is helping with the keratolytic component, and the vitamin E and the ceramides are helping with the hydration component. But there's a lot of good options. The biggest thing is what is going to be sustainable for the patient, because again, this is a chronic condition. So patients are going to, if you see, administrate based on the administration regimen. So that's 3 times a week, like in Durcos, or twice weekly with Nizoral. But then there's also going to be a maintenance phase. So they're going to have to make sure, if they don't want this problem to reoccur sometimes like more severely or just come back the way it was, they have to maintain. So again, moving on to some more options. So you have like some pretty accessible options like the Dove Dermacare or Derma Plus Care Scalp, which is just zinc. You've got the CeraVe Anti-Dandruff Hydrating Shampoo. Another active ingredient with it is zinc. The one thing, like all these are OTC except for the Stiprox, but the Stiprox is the Cycloporox isn't available. Like I don't think there's any Cycloporox shampoos right now that are commercially available. So that's one thing to note. The Stiprox prescription shampoo isn't available at this time. I know it's being compounded by pharmacies, including ourselves, but just to kind of make everyone aware of that. But again, you'll see a lot of these products, they'll vary. Like the Ducrase there has the glycolic acid, salicylic acid and the curcumin. So that just those are keratolytic components. So understanding what those components of the shampoo are going to do based on your patient's presentation, right? Do they need a keratolytic? Do they need a hydrating agent? Do they need like what are we going for? So again, based on that disease continuum, like how severe it is kind of where you're going to treat it from. So OTC shampoos for the more of those mild cases, right, where it's just more so flaking. But then you get to moderate severe cases where there's a lot of itch, maybe there's a lot of like noticeable flaking, redness. So then you're like, okay, how can we help this patient get to more maybe of a mild presentation just so they can manage things and develop more comfort. So yeah, we'll go on. And actually, I'll make a note. So clobetasol shampoo and betamethasone valerate, whether you use clobetasol shampoo, clobetasol spray, like these are all options. The reason there's a place for steroids is because when things are severe enough, at the end of the day, topically, steroids are the most effective anti-inflammatory, right? Based on their mechanism, they work on the entire pathway, right? They're not just working on a single component like your calcineurin inhibitors or your PDE4s. So sometimes they have a place in getting things under control for patients who want treatment results right away. So yeah, just to kind of make that note. So, what are the treatment takeaways? Well, proactive treatment not only alleviates physical symptoms, but also enhances patients' quality of life. So, since sebderm is a chronic condition, a long term maintenance plan is essential. And that's not just with shampoo, sometimes that means with prescription products. So, it's really just gauging your patient. So, if a patient's like, I'm really worried this is going to come back because it's come back before, and maybe it's something on their face, there's a place for using prescription products or non-prescription products on those areas as a maintenance approach, right? So we typically and commonly use like whether it's a compounded ketoconazole with Elidel or Zoryve foam, just with patients who have recurring seborrheic dermatitis on the face. We have a very dry climate in Alberta, so sometimes that's the case. Although they are hydrating, they're using moisturizers. Sometimes that can really kind of be in the back of their mind. So having a maintenance plan is very important for your patient. So multimodal approach may be necessary. So especially when significant scaling on the scalp promotes active ingredients from penetrating effectively. So again, understanding your products, especially those OTC items, is important. If they have a lot of scaling, a lot of like happening on the scalp, using keratolytic kind of coupled maybe with zinc or an antifungal in there is going to help. If there's a lot of inflammation happening, maybe a shampoo might not do enough. So we have to kind of introduce whether it's a topical steroid or honestly the roflumilast foam's great too, as an anti-inflammatory too. But there are some really great, and then also remembering like the components of your shampoo. Is it going to help hydrate the skin there? That's going to alleviate some of the itching. So something like the Durcos. And then product formulation affects adherence. So obviously nobody wants to use a stinky product or a product that they're just not comfortable with. Like no one was going to want to rub an ointment on their face all the time, every day. Or even on a maintenance approach. That's why sometimes people aren't crazy about tacrolimus or protopic ointment using it on the face, and that's understandable. Kind of moving on to like kind of contact time, you'll see a lot of the shampoos that are recommended in dandruff. They recommend like using it for a certain amount of time before kind of rinsing it out. And then looking at products that maybe have a shorter contact time might improve adherence. So really, there's several variables that are going to help impact that. So we'll kind of move into a couple patient cases. The purpose of this is just to kind of get everyone thinking, and I'm sure everyone's kind of seen prescriptions around kind of things. They'll be like, well, why is this being used? So this is a good opportunity to see some of the answers in the poll questions. So yeah, but so you'll kind of see in this individual, so there's sebderm happening in the nasolabial region. So where do we start, right? There's a little bit of scaling, there's a little bit of erythema. You can see again, it's symmetric. It's not just happening on one side of the face. Could this be something else? Like someone might say, well, then maybe this is perioral dermatitis. Well, perioral, you get more papular presentation, right? So we're pretty comfortable. This is sebderm. There's that greasy scaling happening. It's in those hair-bearing areas presenting, a little bit of erythema. Maybe the patient's telling you, yeah, it's a little itchy. I've been suffering from this for quite a while. So where do we start? We want to moisturize. We want to settle the inflammation down. We want to have a maintenance plan maybe in place. So, okay, so see in here. Okay, so yeah, I'm seeing a lot of B happening, and it's great. Like the hydrating cleanser, the Lipicar is AP plus is fantastic. It's a moisturizing cleanser, right? So it helps hydrate the skin, but cleanse the skin gently as well. Um, I'm also seeing like the other component of that is the tacrolimus ointment, the Protopic. We're also seeing the one thing I did mention is sometimes individuals don't like to use ointments on their face, right? That can be a little, it can push them away from wanting to stick to that product just because it's not the most comfortable and it's a twice daily application. So typically they're going to have to do it at some other point of the day. The like options with option A, like yeah, OTC hydrocortisone, it's not like none of these are per se wrong options. The issue there is there's scented soap for face wash. Again, there's a disruption in the skin barrier, so they're going to be more prone to irritation, like irritant derm or contact derm. Um, the chances might be low, but something to be out. We might not want to use a scented product in this case. Um, Option C, 2% keto and pimecrolimus LDL twice daily. Ointment moisturizer, again, it's we want to try to avoid like that ointment moisturizer is really just going to create a barrier sometimes if you're thinking like Vaseline. So option D is might be the best answer in this case, just because you've got the hydrating cleanser, you have a cream moisturizer, you have roflumilast foam, which is the Zoryve foam. That is Health Canada indicated as well. It's not how we're basing the answer, but it might be the best answer because it is a daily application. It is sorry, I'm not. I'm just gonna move this poll. Yeah, so D in this case might have been the best answer just with the cream moisturizer and so on. So I will move on to the next case. Okay. Or sorry, Dom, I might need you to help me out with this. Uh,
Yeah, no problem. I'm just launching that.
oh, there we go. Sorry, I'm just the poll there. Okay, so I think there was two parts to the first question. There was 23A and B. So the second part of this case was the patient reports great results after adhering to recommendations, um, but is worried that they will return soon as they stop. So what's next? So sorry, are people able to interact with the second part? Okay, there we go. Yes.
Sorry about that. Yeah, the share just got sort of jammed, but I think I fixed it up now. Everyone should be able to see part B for slide 23. The new poll is up.
Lovely. And we can definitely go on and kind of, if there's questions pertaining to the polls, you can throw them into the chat as well. So yeah, in part B, we kind of discuss, the patient reports great results, adhering to your recommendations for 4 weeks, is worried that this will return as soon as they stop. What's next? So, and this is a common complaint, right? Patients are going to use their active approach in seborrheic dermatitis. Maybe it's a daily regimen of a prescription product and they got their moisturizer down and everything else is working well. But then they're like, do I have to use it at this frequency or can I cut back? So in this case, yeah, sure. We could say nothing and see what happens. We could just say continue the hydrating cleanser and discontinue other treatments. But if the patient is presenting with a little bit of angst around it, one option is to use a prescription treatment once to twice weekly, just to keep that inflammation at bay, right? To reduce that sebum production in some cases, just because when you have overly dry skin, and then continue using the OTC skin care items. So again, no wrong answer, but maybe that might be the best approach in option C. Okay, so we're gonna move to the next case where we're essentially having seborrheic dermatitis of the scalp. So this is more of a severe, you would say, because you've got that notable thicker, greasy scaling happening, the erythema, the patient's probably really itchy. You can see some excoriations there on the scalp, probably just from itching. So how would we approach this, right? So consider your toolbox, your OTCs, your prescriptions. How would you maintain? Um, Yeah, awesome. So I'm seeing people jumping towards few different options here. So yeah, just like I think having the right idea is having sure you're having a shampoo in there, right? A shampoo based on this patient's presentation, having a catalytic component to your shampoo is going to definitely help. Um, and then there's quite a bit of erythema. The patient's probably a little bit of discomfort, so we want to try to use something to get that inflammation down, right? Maybe we don't want to use and there's nothing wrong per se with using the clobetasol spray. Maybe we're just wanting to be more conservative. And I'm trying to think maybe based on where you're prescribing might be with respect to the jurisdiction. Maybe a clearly indicated product is your rofilomast foam. So option C is a great option, right? Having a hydrating shampoo like the Durcos, having a salicylic acid and antifungal in there. Using that treatment approach, right? I think it's 3 times a week for administration. Using your Zoryve foam and then kind of reassessing in 4 weeks, right? We're not too worried. Like side effect wise, what are we thinking? Well, rofilomast, typically they're saying topically, just watch out for GI symptoms, but your BSA is pretty constricted here in the scalp. Your the shampoos, like when you're using any topical product with like the shampoos, just keep an eye out for local irritation, right? Like is the patient experiencing any irritant derm? Just because anything under the sun can cause a bit of irritation, regardless of how sensitive they might claim it to be. Everyone's different, right? So just say if you notice any worsening of symptoms, irritation happening, just stop and come revisit. But yeah, option C is a great option. We're kind of hitting all the points there. So yeah, so we can move on to the next component of this question. Um, I think part B kind of comes in. Patients has been adhering for 4 weeks. What's next? Nothing. They can discontinue, continue using recommended shampoo, or continue using recommended shampoo and treatment daily. So that's kind of where how are we going to think about it? And in this case, um, you know, it might be a little bit so you're thinking maintenance, right? With respect to this approach. Definitely kind of want to have a shampoo on the maintenance side, and you'll see most of these products will have maintenance instructions associated with them. With respect to your treatment, there's no right or wrong answer. I think in like this is actually based on kind of a real case. The patient sometimes may not want to use a lot of stuff in their scalp, right? Especially maybe a foam, or an ointment or a cream. I don't know if people are able to answer this poll right now. I'm not seeing any results, but ultimately you'll like what's the best approach? People might not want to use a foam all the time in their scalp long term. As notably with people with long hair don't want to because they might not be washing their hair all the time too. So in this case, um, maybe just a maintenance shampoo might be okay. But again, if the patient's very angst about wanting to avoid using avoid this from occurring, and they're very adamant about that, there's nothing wrong with maybe a once weekly maintenance plan for them with an active treatment. So it is really gauging your patient and what their goals are as well, right? Because we obviously have goals of care with respect to what we're trying to achieve, but it's also the patient's overall goals as well. So for the sake of time, we'll kind of move on here. But yeah, B would have been a great option. Nothing wrong with C, but just I think just considering not wanting to put too much stuff in the scalp all the time for patients' preferences. So we'll kind of move on. So some counseling pearls. So seborrheic dermatitis is a chronic condition. Patients will experience periods of maintenance and periods of exacerbation, periods of flare-ups. So there are different treatments and different treatment regimens and approaches based on what's happening. So since onset flares are linked to skin barrier impairment, proper moisturization of the skin and scalp is crucial. So using products that aren't going to irritate, using product and then regularly moisturizing is going to be very important for these patients. Topical steroids play a role, just have to weigh pros and cons, but they do have a place, especially for patients who want to get things under control immediately. Non-steroidal agents serve as effective long-term maintenance approaches. So your TCIs, your PDE4s, a lot of medications in that pipeline too. So they are a great option. And adherence to contact time guidelines are really important too for shampoos, right? We don't want to just treat it like put it on, wash it out 30 seconds later. It's not going to do much for those patients. And yeah, so we'll kind of wrap it up there. I think we're kind of on queue there. So I want to just see this Q&A if we have any questions here.
One in the Q&A for you.
Yeah, so can Nizoral be used more specifically for maintenance? Can resistance occur? So yeah, like it technically can. Like even Nizoral shampoo has been used as body wash. Like the reason we do that, I say that is because working very closely with dermatologists, sometimes we do recommend it as a body wash in some patients. So it can be used more than once a week, but I guess it's really comes down to, is it intended at that point for maintenance or is it for more so for active treatment? And then can resistance occur? Yeah, so interestingly, like we've seen some resistance cases to like kind of traditional antifungals, but it's gonna vary based on I think based on the patient sometimes, based on what's happening there. Like, so I can't give you a straight answer on that.
Did anyone else have any other questions for Ahmed today? All right. Well, if there's no other questions at this time, we will start to wrap it up. But if anyone does have any questions, please do email us at education@opatoday.com, and we'll forward the question to Ahmed, and he can certainly reply to you at that time. In the meantime, I would like to thank Ahmed for coming by today and sharing all of his knowledge and experience on this topic. Thank you so much.
Yeah, my pleasure.
I'd also like to thank L'Oreal for supporting this with an educational grant. And then I'd also like to thank everyone for taking the time to join us today. Thanks again, and have a wonderful day, everyone. Take care. Bye-bye.